or snake bite. Actually, this is on tropical medicine. This is important because definitely one of the 8 questions in the essay paper will be on this area. Harida?
Yes, sir.
So that is one really guaranteed question. So it's very easy. Areas now the question is supposed to be titled tropical medicine, but nowadays we don't see malaria, so we don't ask about malaria as a long case, and filariasis and things like that. There is nothing to ask in a long case. Invariably, and then things like leptospirosis will be asked in under liver also. So invariably, the tropical medicine question will be either on snake bite or on poison. How is Chaturika? Chaturika?
Yes, sir.
Okay. එතකොට හරිනම් හරි කියනවා චතුරිකා ගිවම හරිද? Right, okay. Now I am going to take you through this. One is of course for the exam, and second thing is because it is so important for your work as a doctor. You can save lives if you know this, and patients will die if you don't know this. Also, when you are examined at the exam, say for instance, if this discussion comes up in a long case or something somewhere, you will be expected to have very high standard. Now, if the question is very complex, even average knowledge, people will say, oh, medical student, average knowledge is enough. But when it comes to poisoning or toxicology, it is very important that you have an absolute 100% knowledge and competence in that area, because you will be, as a frontline house officer, you will be the one who will be managing these patients, and you will be expected to have 100% knowledge. Harine Chaturika, so you have to know this. Harida?
Yes.
Now, we will look at, I'm not going to do snake bite today, I'm going to look at poisoning today. And poisoning got them passe. Again, important to remember, though there are hundreds of poisons, only 2 things can be questioned at the exam. Either organophosphate or paracetamol. Other things, there are lots of other poisons, but it is unlikely that anybody is going to give you a long case on, say, propanil poisoning or something as an undergraduate. Never. So if you get a question in poisoning, it is very likely to end up paracetamol poisoning or organophosphate poisoning. Right. Harinera Chaturika?
Yes, sir.
Now we are getting down to a clinical scenario. Now look at this patient. I know that you can see a lot of the slides, but it doesn't really matter. But just look at the question alone. Say you're the doctor in the emergency ward, and a 25-year-old female patient is brought to the OPD or ETU or emergency unit by the relations. She's conscious but drowsy. Conscious but drowsy. So just close your eyes and imagine this patient. You are the ETU, you are the doctor there, a female patient, 25 years, brought on a stretcher, looks drowsy. She's drowsy. Conscious, but you can rouse her if you speak to her, but she's groaning and drowsy. Now, I want you to close your eyes and imagine that you are the doctor there and think of the possible differential diagnosis you will consider in this patient. Of course, I have listed them in the second slide. It doesn't matter. Don't look at that, but just imagine what are the things. So imagine for 5 or 10 seconds, and then we'll discuss what this could be. Harida Chaturika, imagine karada. Chaturika?
Yes.
Okay, you imagine. Fine. Now, I'm not going to ask you, don't worry. Now, I have written 5 possible diagnoses in this patient. One is a very likely possibility is some kind of neurological disorder. For example, a post-ictal stage of epilepsy. Now, if this young woman had epileptic seizure, it's possible that the relations will bring her to the ETU in a drowsy state. She's not fitting anymore, but she's drowsy. That's possible. At the same time, now just imagine if the patient had an encephalitis. Encephalitis, the patient will again be drowsy and be brought in a stretcher. Important to remember, meningitis is a different illness. It does not cause patients to become drowsy or lose consciousness. That you must remember. Meningitis They will have photophobia. They'll want to keep their eyes closed. But when you ask them to open their eyes, they'll be fine. Their level of consciousness and GCS is absolutely normal. If somebody becomes drowsy, it is either encephalitis or a meningoencephalitis. There has to be an encephalitic illness. It's unlikely, I know, but if the patient had an intracranial hemorrhage, it is possible that this patient would become drowsy. ICH would be unusual for a 25-year-old female, but it is possible that that can happen. So a neurological illness such as post-ictal stage of epilepsy, an encephalitic illness, intracerebral hemorrhage, all of these are possible with this woman. Is that all? Not quite. If the patient has had a cardiac arrhythmia, like a very fast ventricular tachycardia or a fast day, patient could actually lose consciousness, become drowsy. That's also possible. Then again, we know that patients who have metabolic disorders, hypoglycemia, can become quite drowsy and be brought to hospital. Now, even this morning, today in the morning, I was in the ward 11. I was doing a ward round, and I really missed your presence by the bedside. I really missed you all. So there was this patient. They said this is a type 1 diabetes patient who has come with some dysphagia, some other problem. And when I just spoke to her and asked her, then kohomada, she with difficulty she opened her eyes and said, "Then hondai," and went immediately back to sleep. So I said that would be very unusual for this patient with dysphagia to feel so sleepy. Then because she has type 1 diabetes, could this be hypoglycemia that she is having now? So then the registrar, Dr. Samir, told me, yes, she had hypoglycemia in the morning and that they gave her some dextrose. We did another capillary blood sugar to see that it was 17 milligrams per deciliter. That's very, 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 very low. I'm surprised that he didn't have a seizure. So whenever somebody is drowsy and looks very sleepy, one of the important differential diagnoses would be hypoglycemia. It could be a poisoning as well. 25-year-old female brought in drowsy. Who knows? She may have taken some poison and that might be why she's drowsy. Is a snake bite possible? Of course, a snake bite is possible. We know that certain snake bite patients get, the bite can cause complications in the brain and even ICH and things like that. Or there can be respiratory paralysis, which can cause the patient to become hypoxic. And hypoxia can cause the patient to become unconscious. Again, snake bites, snake venom doesn't make patients become unconscious. Snake venom doesn't make people become unconscious. But a complication of a snake bite could result in a patient becoming unconscious. Harida, Chaturika?
Yes, sir.
Okay. Then these are some of the differential. You could always say hepatic encephalopathy or uremic encephalopathy. But I think considering a 25-year-old female, I think priority diagnosis, if she is brought in drowsy on a stretcher to the ETU, these would be priority diagnosis. What are they? A poisoning, a snake bite, a post-ictal stage of epilepsy, maybe encephalitis, cardiac arrhythmia, something like hypoglycemia. Now, if it was a 65-year-old person, you could always say the patient has had a massive stroke. That kind of thing is also possible. So that's the differential diagnosis. Now, what will you do if this patient comes to the ETU? Obviously, you're trained to do airway breathing and circulation assessment of the patient. We will do that, and if there are problems, we'll try to correct them. But at the same time, we take a very quick history. Quick history can not the kind of histories that we force you all to take in the ward. Gamma kohe, nama kohe, gamma kohe, all that. But here you would take what is called a very quick and a focused history. Now, look, this is what they say. The patient had been feeling sad and down for a couple of weeks due to a breakup of a relationship. When she was found in a drowsy state by the family, she told them that she poisoned herself by drinking from a bottle of agrochemicals. It has been about 1 hour since she has taken the poison. The family members have given her some soap water and coconut milk to make her vomit. They say she did not vomit. People use these agents such as soap water and coconut milk and even excess of water to induce vomiting as a home remedy for poisoning. A lot of people try that. It's interesting, but then these people have tried that and that have not succeeded. And then, of course, from your point of view, what do you do when a patient comes? If you are in the ETU, emergency treatment unit of one of the, say, base hospital also, most of the time you have access to a monitor. You'll connect her onto the monitor. You will connect her onto the monitor, and the monitor shows some cardiac tracing. It shows a regular rhythm, and then saturation SaO2 is 92%. That's a bit low. You would expect somebody without any prior respiratory illness to have an SaO2 of more than 94. 92 would be a bit low. Blood pressure is 90/60, could be normal, but most probably a bit low. Pulse rate is a bit odd. It's 68 per minute, or heart rate is 68 per minute. That's again a bit odd because you would expect somebody who is very unwell to actually have a stress response and have a heart rate of more than that. But this is what you find. Right. Chaturika, are you still with me? Are you with me, Chaturika? Okay. Wait. Then api වෙන එක්කෙනෙක්ව පත් කරමු. Shall we appoint Beruni Narmada as the person who can answer me? Beruni, are you hearing me?
Yes, sir.
Right, Beruni. Let's get on with the talk. Hari. Then මෙන්න මේ කතාව ආව එළියට. දැන් මම ඊළඟ වාගේ අහන්න පුළුවන් අහන ප්‍රශ්නේ තමයි. Now, the relations have said that the patient took an agrochemical. සාමාන්‍යයෙන් ලංකාවේ ලොකු agrochemicals දැන් තියෙන්නේ දේවල් තුනක් විතර. One is organophosphate. Second thing is people take glyphosate. And third thing is people rarely take carbamates. There are other things also, but these are the common ones. And out of the common ones also, the commonest is an organophosphate. So in all probability, this patient has taken an organophosphate agrochemical keyword. Now carbamate and glyphosate is not dangerous at all. Carbamate is fairly bad, but OP is the most dangerous. So immediately what your job as the doctor there should be to look for features of organophosphate poisoning in this patient, young female who has been brought unconscious, where she has confessed to taking agrochemicals. Benunita matakada danne how you would at least what are the clinical features of organophosphate poisoning? Matakada answer.
Vomiting, nausea, diarrhea, and salivation.
Very good.
Sweating.
Very good.
And
excellent. That's fine. ඕක අපි පොඩි ලස්සනට ඔක්ක බෙදමු. බෙදන්න කලින් මට දැනගන්න ඕනේ. දැන් කොහොමද මේ features එන්නේ කියලා ඉවරලා. Now when I asked you clinical features, if you know the pathophysiological basis of these things coming, then it will be very easy for you to answer. Now Beruni, do you know the fundamental action organophosphates have in the body? එක මොකක් හැටියටද වැඩ කරන්නේ ඇඟ ඇතුලේදී?
It inhibits acetylcholine esterase enzyme.
Excellent answer. Very, very good. It is a acetylcholine esterase inhibitor. ACHEI. Acetylcholine esterase inhibitor. එතනින් ඒක විතරක් මතක තියාගත්තම ඇති, then you can work it out. Now we know that acetylcholine esterase, what it does is it breaks down acetylcholine. So if acetylcholine esterase is inhibited by organophosphate in the body, acetylcholine accumulates. It collects in the body. Then certain problems occur. Then උදාහරණයක් හැටියට මතක තියාගන්න ඕන එක තමයි, these are the three receptors, Beruni, on which acetylcholine will act. You might remember muscarinic receptors, which are in postganglionic membranes of the parasympathetic nervous system. Then nicotinic receptors, which are to do with skeletal muscle. It acts at the neuromuscular end plate. And then, of course, there are certain central actions in the brain and the nervous system. So if you know that acetylcholine acts through these receptors, and if you have an excess of acetylcholine, then we can figure out what would happen, which will tell us what the clinical features are. So මේවා තමයි බෙරුණි අපිට උගන්වන්න උත්සාහ කරේ. Muscarinic is to do with parasympathetic. ඒක මතක තියාගන්න sludge කියන එක. Sludge කියන්නේ S වල දෙකක් තියෙනවා. Salivation, sweating දෙකම කිව්වා බෙරුණි. Lacrimation අඳුරු වෙනවා. Urination, defecation, gastric cramps and emesis. So this is called sludge. In addition to sludge, you get certain features on the respiratory system, which will be wheezes, crepitations, and the patient can become dyspneic. On the heart, it can work and cause bradycardia and hypotension. Then on the pupils, it can cause, acetylcholine causes pinpoint pupils, and because of that, a blurred vision. So these are the muscarinic. Sludge theana. In addition to that, wheezes, crepitations, and dyspnea in the lungs, bradycardia and hypotension in the heart, in the nervous system or in the eyes, you get pinpoint pupils and blurred vision. Sludge කියන්නේ sweating, salivation, lacrimation, urination, defecation, gastric cramps and emesis. මතක තියාගන්න පුළුවන්ද පෙරුණිට ඔක්කොම ටික?
Cancer.
Right, no problem. Then comes the muscarinic, nicotinic receptors. Acetylcholine action due to organophosphate is not very pronounced on nicotinic, but it can cause fasciculations, muscle weakness, and actually cranial nerve palsies as well. So that's also easy to remember. Fasciculations, muscle weakness and paralysis, and cranial nerve palsies. Then, of course, centrally, it can again cause problems. Centrally, confusion in the puluang and seizures in the puluang due to organophosphate poison. Then, right. Can Beruni remember all them? Then in an essay question, you will never be asked for all the clinical features. But when it comes to an MCQ, somebody could just say blurred vision is a clinical feature of organophosphate poisoning or something like that. So then, because of that reason, it is important to remember all these features. Then you can answer all questions. And also, again, you could be asked the pharmacological basis or something. And then you can, not pharmacological, pathophysiological basis. And then you can actually explain how these things occur. So for any questions, Beruni to prashna tiyinawada දැන්ට මම උගන්වපු අය?
No, sir.
Anybody else? ළමයි කවුරුම හරි තව කාට හරි sorry තව කාට හරි මොන හරි problem එකක් තියෙනවද මම උගන්වපු ඒවා දැනට? Anybody else? Anything that you all want to clear up so far? නැද්ද? Okay. Then ඊළඟට so we will look for these features, and if the patient has taken a bottle of agrochemicals, and if these clinical features, for instance, if there are fasciculations and the patient is sweating a lot, patient has bradycardia, then the patient has vomiting, nausea, urinary, if the patient has wheezing, all of these pinpoint pupils, then you can fairly confidently diagnose that the patient has taken organophosphate in this bottle, even if you have not seen the bottle. මෙතනින් මම පොඩක් ඩයිවර්ට් වෙලා ඔයගොල්ලන්ට තව පොඩි මම දන්නවා මම කතා කියනවා ඔයගොල්ලන්ට උගන්වනකොට කලිමුත් මම කතාවක් කිව්වනේ. ඒ වගේ තව පොඩි කතාවක් කියන්නම් මෙතනදී. This morning I saw another patient in the ward. This patient has had, they said patient came with fecal soiling. ඒ කියන්නේ fecal incontinence එකක් එක්ක ආවේ young woman, to see that she had been diagnosed as having myasthenia gravis, for which she had been started on pyridostigmine. The Beruni දන්නවද pyridostigmine වල action එක මොකක්ද කියලා?
It will increase acetylcholine at the neuromuscular junction because in myasthenia gravis there is an autoantibodies against neuromuscular junction receptors.
You are an excellent answer again, very good. What I want to know is කොහොමද pyridostigmine, what is the pharmacological basis? How does that increase acetylcholine at the neuromuscular junction?
It will inhibit acetylcholine esterase enzyme.
Absolutely. So you're spot on. Brilliant, Beruni. එතකොට what can you say? OP and pyridostigmine are equal. They have exactly the same action. Exactly the same action. ඉතින් මම කවුද බෝඩ් එකෙ මුත් අහුවා. So okay, don't challenge එකක් දුන්නා. Right. Can you tell me this patient is on pyridostigmine? Can you tell me any other group of patients who have something similar to pyridostigmine injection in the ward කියලා? මම දුන්න හොඳ challenge එකක් ඒගොල්ලන්ට. මම ඉතින් ප්‍රශ්නේ අහන්නේ ඔය වගේ කෙලින් නෙවෙන්නේ අහුවේ අනිත් පැත්තට හැදුවේ. So of course Dr. Samira, who has registered here, kalpana kalwa, so it's organophosphate poisoning. So what I want you to appreciate is pyridostigmine, non-neostigmine and organophosphate, they have absolutely the same action. So then the question was, prashne avila tibune, can pyridostigmine, now that the patient's original problem was fecal incontinence. So the question was, can pyridostigmine as a side effect cause fecal incontinence? The mama going to give a pyridostigmine, I have no idea. I have never read that as a side effect. But then pyridostigmine action is the same as organophosphate, is acetylcholine esterase inhibitor. And I know for sure organophosphate patients, poisoning patients, get fecal incontinence. So I'm sure if you read pyridostigmine, that must be a side effect. So we read pyridostigmine and found it to be a side effect. So I divert a little bit again to teach you the similarities between pyridostigmine and organophosphate, and the fact that you now know this rare side effect of pyridostigmine, the mama anal incompetence, or that is fecal incompetence, and the reason is the same action. Harine? Right. So these are the features. Defecation there can be, involuntary defecation. Right. Now we go to the next bit. Now you want to treat this patient, organophosphate patient. So we know that treatment of poisoning මහකැලියන් නෙවෙයි දේවල් තුනයි කරන්න තියෙන්නේ. ඔයගොල්ලෝ දන්නවනේ මාගොල්ලෝ උගන්වන්නේ මේකට 2යි මේකට 3යි මේකට 4යි කියලානේ. So මේකටත් මම කියන්නේ there are මහදයන් නැහැ, there are only 3 things to be done. ඒක ඔළුවේ තියාගන්න හොඳට 3යි කරන්න තියෙන්නේ කියලා. විභාගයේ ප්‍රශ්නයක් ඇහුවත් 3යි කියන්න තියෙන්නේ. ලෙඩෙක් දැක්කත් 3යි කරන්න තියෙන්නේ. මම ඕඩර් එක ඇහුවත් 3යි කියන්න තියෙන්නේ කියලා. තුන මොකක්ද? පළවෙනි එක තමයි you must see whether gastric decontamination can be done for this patient with poisoning. Now these 3 principles apply for any poison, any, not just OP, any මේ ලෝකේ ඕනේ poison එකකට මෙච්චරයි මේකේ කලාව. So first question to answer is there a place for gastric decontamination? Gastric decontamination තමයි ජාති තුනනේ තියෙන්නේ. Now one is we can get the patient to vomit, induction of vomiting, induce emesis. දෙවැනි එක තමයි you can do something called gastric lavage. Now a lot of people mix up induction of emesis with gastric lavage. Gastric lavage කියන්නේ ලෙඩුන්ට වමනය කරන එක නෙවෙයි. Gastric lavage is where a doctor puts an NG tube into the stomach, puts saline into the stomach and aspirates the saline back, and with the saline aspirate the gastric content so that gastric decontamination or intestinal absorption will get reduced. So do not mix it up with induction of emesis. Induction of emesis කියන්නේ gedara hari ඇට hari කවුරු hari කරන මේ දඩාට මොනවා hari කුරුම දීලා වමනේ කරනවා. පැහැදිලිද බෙරුනි? Are you with me?
Yes, sir.
Yeah, දෙවැනි දේ that you need to do is, first thing is gastric decontamination. Second thing is, once you have arranged that, you must think, is there a antidote for the poison that I am giving this patient has taken care of? සමහර most of the poisons don't have an antidote. But occasionally, some poisons have an antidote which can reverse the effect. So you will see whether there's an antidote. Now, for example, what is the antidote Beruni for organophosphate? What is the commonly used antidote?
Atropine or pralidoxin.
Atropine or pralidoxin. So we know that those can be used. That's the second thing. Third thing is, ඔය මොනවා කරත් GI decontamination කරත් නොකරත් antidote තිබුණත් නැතත් ultimately if the patient has taken a lot of poison and that gets absorbed, patient will have multi-organ failure. That failure can be the kidney failure, liver failure, coagulation failure, or respiratory failure. ඔය හතර පහනේ තියෙන්නේ. Respiratory failure. Cardiac failure is very unusual for a poison, but usually these are the four things: respiratory failure, liver failure, cardiac failure, coagulation failure. In a complication poison complication then your next job is to support the patient's failing organ. If the kidney is failing, you support with fluid and then dialysis. If the liver is failing, you might give NAC. You might give fluids. You might actually do a liver transplant even. If the heart, if the lungs are failing, you can ventilate the patient, more than the pulang. So very simple. Poisoning management, 3 things to do: gastric decontamination, antidote, and supportive therapy. Gastric decontamination induction of emesis, gastric lavage, and activated charcoal. The අපි මෙතනදී තීරණයක් කරගන්න ඕන අපේ patient මොකක්ද ගැලපෙන්නේ කියලා. Now first thing is induction of vomiting. Now what I want you to remember is ඉස්සර කාලේ there was a practice where patients were given things to make them vomit, and it has been proven by research over many years that it causes much more harm than any benefit that there can be. So the world gave up induction of vomiting around about 1985. මීට අවුරුදු 35කට විතර කලින් තමයි මුලින්ම research ආවේ. Definitely by 2000 they had given up vomiting. Sri Lanka still vomits even 20 years after, because පරාණ දොස්තරලා ඊළඟ දොස්තරලාට කියලා still people make others vomit. So that does not want. So I want you to tell the whole world, when you become a doctor, there is no place for induction of vomiting in a patient after poisoning. හරිද වෙරුණි? ඒ ගැන හිතන්නවත් එපා. වෙරුණි එහෙමද?
Yes, sir.
Then of course second thing is gastric lavage. Gastric lavage, there are only for all of you. Gastric lavage karanna hati man ogalanta kiyala dunna. It has to be done by you as a doctor. You will put a gauge 18 ng tube and then you'll give about 200 milliliters of normal saline into the stomach, aspirate that, and ovage cycles 3ක් කරනවා. එහෙම තමයි කරන්නේ gastric lavage. Now the important thing to remember is that can also be a very dangerous procedure. There are 2 reasons why you will do a gastric lavage. මේ දෙක fulfill වෙලා තියෙන්නම ඕනේ. One is it is ineffective if it is done after 2 hours of taking the poison. You have to do within 2 hours. So is this patient within 2 hours? Yes. අපි මුලදීම මං කිව්වා within 1 hour of poisoning තමයි ගෙනාවා. So time period is okay. හැබැයි time period එක මත වෙන හැම කෙනාටම gastric lavage එක කරන්නේ නැහැ. Only those who have taken a life threatening injection. Organophosphate is life threatening. එතනදී කතා කරන දෙයක් නැහැ. But අපි තුන් patient කෙනෙක් ආවා කියලා diazepam tablet 10ක් බීලා diazepam tablet 10ක් is not a life threatening injection. Life threatening injection එකක් නොවෙනවා නම් no gastric lavage. Within 2 hours ගෙනාවේ නැත්නම් no gastric lavage. So those 2 conditions have to be fulfilled. ඒ වගේම if the A fulfill not a pass, you have to make a decision. Are you going to just put an NG tube and do this, or do you have to intubate the patient, cuff the endotracheal tube, then put an NG tube and do this? If the patient's GCS is low, if the patient is drowsy, then you have to put an endotracheal tube and then secure the airway, make sure that patient will not aspirate. මතදන අපි ඔහේ fluids දානවා ගන්නවා drowsy patient කෙනෙක් aspirate වෙලා මැරෙනවා poison එකෙන් නෙවෙයි අපේ treatment එක. හරිද? ඒකින්ද this patient is ideally gastric lavage ගලපෙනවා යාට because she has a life threatening injection less than 2 hours, but it can only be done if you as the house officer you are confident of intubating the patient. You manage to put a tube and cuff the tube and then do it. Water tube එක දාන්න බැරි නම් කරන්න එපා because it's too dangerous. හරිද? So that's why I've said gastric lavage yes. Third thing is activated charcoal. Activated charcoal වල criteria දැනගන්න ඕනේ. ඒක එකයි තියෙන්නේ. That is it has to be done within 2 hours. දෙකෙන් පැය දෙකයි. There are rare exceptions. Yellow oleand පැය 4ක් විතර වෙනකන් කරන්න පුළුවන් activated charcoal. That is because yellow oleander causes a delayed gastric empty. That is the reason. But usual other poisons for 2 hours. So again, easy to remember. Gastric lavage and activated charcoal only within 2 hours. So if the patient comes within 2 hours, you can. එතකොට ඒකේ මත තියන්න ඕනේ කතාව තමයි මේ patient ගැලපෙනවා. Yes, you can do it because patient has come within 2 hours. And if the patient is drowsy, you can give activated charcoal via the NG tube after endotracheal tube intubation. NG tube එක දානවනේ for gastric lavage. ඒ NG tube එකෙන්ම activated charcoal දෙන්න පුළුවන්. If the patient is conscious and GCS 15, then you don't have to put an NG tube. You can ask the patient to drink the activated charcoal. මේ activated charcoal කතාවේ තියෙන වැදගත් දේ තමයි ඒකත් ඔයගොල්ලෝ මතක තියාගන්න ඕනේ activated charcoal ඒකේ ඉන්නේ 50 gram bottles වල ඉන්නේ activated charcoal. ඒ gram 50 gram bottle එක අරගෙන ඔයගොල්ලෝ දිය කරන්න ඕනේ. ඔයගොල්ලෝ දිය කරන්න ඕනේ 50 gram bottle එක in 200 milliliters of water and get the patient to drink. Now, its action is something called adsorption. Adsorption කියන්නේ the poison binds around the charcoal particles. Charcoal particle එක වටේ ඇලෙනවා. ඒ කියන්නේ absorption කියන්නේ උරා ගන්නවානේ adsorption. AD adsorption කියන්නේ ඒක වටේ අලවගෙන රඳවගෙන when it is passed through stools, then the poison is taken out of the body. So that is how activated charcoal works. So in this patient, it is important for you to mention that you will give activated charcoal, but with the NG tube after endotracheal tube insertion because the patient is drowsy. Harida Beruni?
Hari sir.
Understand so much. Hari. Then mama hoya gannan tawa kawa hari Beruni ta karadara kara ඇතිනේ. අපි hoya gamu Jayanti, can you hear me, Jayanti? Right. Right. We'll carry on with the conversation, Jayanti. Right. Okay. And then, what are the antidotes which are useful for that? Then, Mama kiwe api kalpana karan api oruwe thunane wada karan GI decontamination, antidotes, and supportive therapy. So, api GI decontamination kata kaliwara. So, what are the antidotes which are useful to this patient? As we discussed earlier, as Beruni said, atropine and pralidoxine. The make it Danaganone Jayanti very important. You must always know the pharmacological basis of giving these medicines because that could easily appear in a question, and then you understand what. So atropine, we said, atropine has a anticholinergic action. Cholinergic and choline acetylcholine viruddha action because we discussed that OP causes is acetylcholinesterase inhibition, increasing acetylcholine. So what we need is a anticholinergic action. Acetylcholine නැති කරන එක. So atropine වල තියෙන it inhibits excess acetylcholine activity both on nicotinic and muscarinic receptors. හින්දා දෙකටම ගැලපෙන හින්දා අපිට atropine එක දුන්නම වැඩේ සෑහෙන දුරට shape කරගන්න පුළුවන්. So that is the pharmacological basis of giving atropine, or you could even say physiological basis of giving atropine. Then what about pralidoxime? Pralidoxime, it's a different action. These organophosphates get highly bound to acetylcholine esterase, and that's how it inhibits. So pralidoxime goes and breaks the bond between organophosphate and acetylcholine esterase. Eka kadala tamai pralidoxime acts. So that's the ultimate solution. Atropine palastara visadumak denne. It just simply inhibits acetylcholine, but original ප්‍රශ්නේ තියෙන තැන විසඳන්න එක බලාපොරොත්තු වෙන pralidoxime වලින්. හරිනේ ජයන්ති?
Okay, sir.
Anybody else කාට හරි මං කියපු දේවල් වල දැන්ට තේරෙන්නේ නැති කැලලක් තියනවාද? Anybody? Any questions at all? I'll wait for 5 seconds.
Sir, so does that mean pralidoxime is superior to atropine?
No, it doesn't. Not at all. ඔයා අහපු ප්‍රශ්නේ හින්දා මම මේකේ කතාවකුත් කියන්නම්. මේකේ ලස්සන කතාවක් තියෙනවා. Atropine is definitely the immediately acting, the one which will save the life, right? But we are worried that atropine එක නවත්තපු ගමන් it's a temporary solution. Atropine නැවැත්තුවොත් if the bond is firm between organophosphate and acetylcholine esterase ටික වෙලාවකින් ආයෙසර ප්‍රශ්නේ පටන් ගන්න කියලා. හරි? So because to overcome that, as a long-term solution, we adopt pralidoxime. It is not that pralidoxime is better. Atropine is certainly the life-saving and immediate measure, but long-term solutions are sought with pralidoxime. Okay, මාර කතාවක්. මේ කතාව ලංකාවේ ඉතිහාසයේ හරි වැදගත් කතාවක්. Medical ඉතිහාසයේ. Now you all know that we had a civil war in the north some years ago. And at that time, at the same time, around about early 1990s, or late 80s, early 90s, Lankawe, the suicide rate was very high. So much so that at some stage, I can't remember the years, Sri Lanka recorded the second highest per capita suicides in the world. For some reason, people committed suicide so frequently those days. So everybody was drinking organophosphate. So eka hinda apne health authorities order kara large doses of pralidoxime to treat patients with organophosphate poisoning. Itakota katawak gaya, I don't know who started it, probably LTTA started the story that Sri Lankan army is getting ready with chemical warfare. They are going to use organophosphates as a chemical warfare agent, and that is why the Sri Lankan government is stocking pralidoxime so that they can give the pralidoxime to the army soldiers so that they don't get affected. Only the LTT gets affected, or civilians in those areas get affected. It was so strong that actually the export of pralidoxime to Sri Lanka was banned, and for about 8-9 months, ලංකාවේ ප්‍රලිඩොක්සීම් තිබුණ නැහැ. එහෙනම් නේද ජයන්ති මං කියන කතාව? එතකොට මේ වෙලාවේදී ප්‍රොෆෙසර් නිමල් සේනනායක, the great නිමල් සේනනායක did a brilliant research. මිනිහා මොකද කරේ? organophosphate වලට atropine විතරක් දීලා ඉවරලා ඒ දවසේ තියෙන ප්‍රලිඩොක්සීම් ඒක විතරක් manage කරලා he recorded the data. And when pralidoxime became subsequently available, our health authorities went and told whatever governments that we are not stockpiling pralidoxime for chemical warfare, just that everybody is taking organophosphate here. WHO they permitted pralidoxime to come back. So what Professor Nima Sennaga did was he had a cohort of patients who were treated with atropine alone, and then he had another cohort who had atropine and pralidoxime. ආවට පස්සේ so from that moment onwards, local pralidoxime in the management of organophosphate after Professor Nima Senaka's research, and still we have not given up on pralidoxime. We think that there may be a marginal effect we give, but as per your question, what's your name, please?
Vimarsha, sir.
Yes, Vimarsha. So answer your question is atropine is far more effective than pralidoxime, and that concept was proved by a research done in Sri Lanka by one of our great physicians. ඇත්තටම ගත්තම ලංකාවේ original research වලින් මේ ලෝකෙට දේවල් හොයලා කියලා දීලා තියෙන හරි ටිකයි. This is one of them. ඒක වගේ තව එකක් ඔයගොල්ලන්ට අදම උගන්වනවා. හරි නේද? So number 1 is atropine. Any other questions, please? Thank you for asking the question. Any other questions? Right. I'll move on. Then comes the thing. Now, then අපි දන්නවා clinical features තියෙනවා කියලා ඔයාලට first way. Atropine දෙන්න ඕනි කියලා දන්නවා. අපි gastric lavage එකක් දුන්නා. What are the clinical features which suggest that urgent IV atropine is work? Because if you know this, you will save many lives in the future. Many lives in the future. And you will pass the exam also. මේ පහ මතක තියාගන්න. 6 less than 80 නම් දෙන්න ඕනේ. If there are wheezes and crackles or auscultation in the lungs, then no. If the pupils are small, you have to excess sweating in the axilla, you are supposed to do, but that's a very difficult thing to measure. So I usually advise people to go on their bar ones. If the pupils are small, yes. Systolic blood pressure less than 80, yes. Pulse rate less than 80, yes. Wheezes and crackles in the lungs, yes. So you will give urgent IV atropine. මතකද ජයන්ත මතකද දැන් පහ?
Yes, sir.
අහන්නේ මතකයිද? මතකයිනේ? Everybody can remember these 5 life saving information. හරි? medicine වල කටපාඩම් කරලා දැනගන්න ඕනේ දේවල් තියෙන්නේ ටිකයි. This is one thing කටපාඩම් කරලා දැනගන්න ඕනේ. Okay. ඊළඟට ප්‍රශ්නේ මම අහනගත් සදාකල් මතක තියෙන්න ඕනේ if you are ever going to treat in a medical ward. How to give atropine in a patient with OP poison. Usually what happens is we will open the poisons book and look and treat. Atropine has to be given so rapidly you will not have time to look at the book. So you must know it by heart and because you have to do it very rapidly. ඔයගොල්ලන්ට තේරෙයි මම කිව්වම ඇයි මම කියන්නේ කියලා පොත බලන්න වෙලා හිටින්නේ නැහැ කියලා. මෙන්න මේක තමයි කතාව. You see this drowsy patient, family says that she has taken an agrochemical, examine to find that she has features muscarinic, rotinic or organophosphate poisoning, arrange intubation, arrange gastric lavage, start the antidote atropine. How do you start? කෙලින්ම wire හතරක් කියමු 3 to 5 කියලා මම කියන්නේ. I say always remember, break 4 wires. Break 4 wires. එක wire එක atropine has 0.6. Break 4 wires or 5 wires unot it is about 3 grams. Give that as a bolus, not as an infusion. Bolus එකක් කියනවා. ගහලා ඊළඟ මම අහනවා මේක step by step අහනවා. එතකොට then my answers you will come back and assess. Come back නැති ලඩා ගාවන ඉන්නේ. Assess the patient in 5 minutes. විනාඩි 5යි. because atropine is a very short acting medicine. You have to make a dose second dose very quickly. So look at the patient in 5 minutes and again look at the 5 features. SBP kiyada, pulse kiyada, lungs kohomada, is there how are the pupil sizes? If any of those are still there, it says the systolic blood pressure is less than 80, second dose of bolus atropine is given. Now second dose you do not give 4 vials but you double the vials. හතරක් දීපේක 8ක් දෙනවා. 8ක් කැඩුවා ගැහුවා. 8ක් කැඩුවා කෙලිම එක සිරින්ජ් එකකට අරගත්තා නීඩ් ගැහුවා. ආයි ඩයිලූට් කරන්න නැහැ මොනවත් නැහැ no infusion nothing. 8ක් ගැහුවා. Then reassess the patient in another 5 minutes. Is the systolic blood pressure less than 80? Is the diastolic, is the pulse rate less than 80? Is the respiration? Give the stethoscope to see whether the lungs are clear or not. If the lungs have wheezes or palpitations, next dose to do. Pupillary dilatation usually takes some time, and at that exact another lungs. Give the next bolus. විනාඩි 5න් 5ට යහම මුලින්ම 4යි ඊළඟට 8යි double 16 vials every 5 minutes. So 16 vials break කරා. Each vial has 0.5, so you will be giving 8 grams of 8 milligrams of atropine. So you will give the next dose and දාසයක දුවට පස්සේ again versus the patient in 5 minutes time. So I often ask like දාසයට පස්සේ අයි 32ක් දෙන්න නැත්ද කියලා.
So if you are doubling, why can't you? I think the answer is because you are checking every 5 minutes. You just do not have time to break 32 vials. What happens is make a das attack gavana. You tell the nurse to break another 16 vials next time within the next 5 minutes. So and not just break the vials, but draw it into a syringe and keep. And in 5 minutes time, when you assess if any of the physical features are there, then you will get the next dose of atropine. So you will have to keep giving every 5 minutes 16 vials of atropine, that is 8 milligrams of atropine, till the physical parameters are normal. Normal can systolic blood pressure less more than 80 karnakan, pulse rate more than 80 venakan, and lungs become clear. Are you clear with what I said, Janti?
Yes, sir.
Right. Then now once you have got the first hurdle, that is clear, then you can stop giving bolus doses. You can set up an infusion. Now, how do you set up an infusion? How much do you give in an infusion? Eka roughly kiyanne මෙතෙක් කඩපු වයර්ස් ගන්න තියන ඔක්කොම අපි තුමු සමහරට වයර්ස් බකට් ගණන් කඩන්න වෙනවා. ඒ වයර්ස් කඩලා දුන්නා කියලා 100ක් to get to this place. එහෙමනම් ඒකෙන් පහෙන් එකක් ගන්නවා 20%. that is 20 wires අරගෙන 20 wires කඩලා ඒක normal saline 500 එකකට දාලා ඒක 500 එකකට දාලා 500 200 දාලා and then give that over 1 hour. So every hour patient has to get the infusion where the total number of vials in that infusion will be 1/5 of the total number of vials that you have to break when you are giving boluses. පැහැදිලිනේ? bolus දෙන වෙලාවේ vial 200ක් කඩලා තිබුණා නම් 200න් පහෙන් එකක් කියන 40යි vial 40ක් කඩලා ඉවර වෙලා හැම පැයකටම vial 40 කඩ infusion එකකට දාලා every hour you give and then slowly reduce the atropine, making sure that the pulse rate stays more than 80, systolic blood pressure remains more than 80, and lungs become clear. So you will have to go on with the atropine infusion for a long time. Because as we discussed, atropine vagin karanne not the breaking of the bond between organophosphate and acetylcholinesterase. All it does is prevent the action of excess acetylcholine, but excess acetylcholine is there. So the moment atropine infusion is stopped, the acetylcholine will start acting again. The ultimate solution will come when organoacetylcholinesterase, which is bound to organophosphate, gets destroyed. So that might take a few days. So you can't stop atropine in a hurry. If you stop atropine in a hurry, what will happen is patient will again get the cholinergic features. Now, if you're working in a smaller hospital, you must, if you get a patient with organophosphate poisoning, you must never transfer the patient as soon as you see the patient. Now, that will be your job if you're a small hospital doctor. You have to bring the patient, resuscitate the patient to a situation where you have put the patient on an IV infusion, and then you can transfer to a bigger hospital if you want. Harita Jayanti,
Yes, sir.
is there anybody who is confused about this? Make a pahadili nati kawuru hari innawada? Anybody who wants to ask any questions? Anybody? Right. Okay. Shall I get Kanchana? Can you hear me? Kanchana, can you hear me?
Yes, sir.
Kanchana, sorry. Kanchana, my next question is, how is pyridoxine given? That is not necessary. Pyridoxine is not used urgently. You can quietly look at the book and see. I also don't usually remember. So what you do is you get 1 gram of pyridoxine and that is supposed to be given as an IV loading dose over 20 minutes, and thereafter IV infusions to be given in addition to atropine. Atropine එක cannula එකකින් යනවා, pyridoxine අනිත් එකෙන් යනවා. Pyridoxine infusion rate and all that you can quietly read from a book. All you have to know is pyridoxine IV infusion එකක් හරියට දෙනවා in addition to atropine. It is not instead of atropine නෙවෙයි. in addition, because the actions are very different, and atropine is a life-saving medicine. Important thing to remember is when you give pralidoxime, you have to give pralidoxime for longer than atropine. Atropine ඉවර කරලා අඩුම ගානේ පැය 24ක් pralidoxime දෙන්න කියලා තමයි කියන්නේ. That is, you can understand the logic. Now, organophosphate and ACE inhibitors, acetylcholinesterase inhibitors, vanilla තියෙන එකක් හැදුවේ නැත්නම් remaining acetylcholine will again act and cause problems. So, atropine දවස් 4ක් දීලා නවත්තන්න පුළුවන් නම් ටික ටික අඩු කරලා that's okay, but pralidoxime has to be continued on till day 5. හරිද කාංචනා?
Yes, sir.
දැන් තව පොඩි වැදගත් කතාවක් තියෙනවා. There's something called intermediate syndrome. Now, intermediate syndrome, as I told you, is again මේ ලංකාවේ original research කරලා හොයාගත්තේ හරි ටිකනේ තියෙන්නේ. මන්ට intermediate syndrome was again discovered and described to the world by the great professor Nimal Senanayake. He was a professor of medicine at Pennsylvania. You might know him. He did some teledramas. He did a lot of books. He has won presidential literary awards. He's a great man. He's the one who described. Now the question is like, very interesting කතාව මම ඒත් බැලුවා ඒ දවස්වල ඇයි මේ intermediate syndrome කියන්නේ? මේක මාර කතාවක්. ඇයි මේක නම intermediate? We know that in the acute stage patients can have acetylcholine causing muscle paralysis and nerve malfunction. Acetylcholine action in the nerves malfunction and patients go into respiratory failure and die, neurological problems, and that's acute. Then of course the world had heard that when somebody takes organophosphate, about 3 months after organophosphate ingestion, patients have been known to get a peripheral neuropathy. So that was termed the late complications of organophosphate. So we had the acute and the late. And then of course, when Nimal Senanayake discovered this, which happens on the 4th day or so of the illness, he named it intermediate syndrome. So that is how that name has come. Usually occurs between 3rd or 4th day of organophosphate poisoning. The exact mechanism of this is not certain. Some people believe that organophosphate is a highly fat-soluble compound, that part of the organophosphate which is absorbed does not go and get bound to acetylcholinesterase inhibitors, but they actually go and get bound to fat tissue in the body. And ඊට පස්සේ අපේ atropine acetylcholine balance කරලා දානවා එහා පැත්තේ. Organophosphates get released onto the circulation, and then that causes, after we stop atropine, the patient again to have another crisis. Atropine that causes another crisis. So nobody really knows the exact mechanism of this, so don't worry about it. What is important is to understand what exactly happens. So on day 4, the patient was recovering from organophosphate poisoning. So the patient recovered sufficiently, and you stop the atropine in 3 days, and you're giving pralidoxime, and you're planning to stop the pralidoxime on day 4. And on day 4, the patients develops neck muscle. Patient is unable to lift the neck off the pillows, and patient feels a bit weak and unable to get down from the bed, and the respiratory effort reduces. Now, what you must remember is make a lazy misread. Now, imagine now you are measuring pulse rate, blood pressure, measuring lungs, and all that, auscultating lungs. Here the patient is very quiet. Patient is breathing less and less, and he will not complain. He can't get out of the bed. He doesn't have the strength to get out of the bed. He can't even lift his neck. Nobody checks ne. Oka baluwema naththam ahuwenna. So organophosphate poisoning, on every day when you go near the patient, you must check whether the patient can lift the neck off the bed, and also ideally check vital capacity with a bedside spirometer every day to see whether the patient's respiratory capacity is going down. Ultimately, patient will go into respiratory paralysis and death. And because it's such a quiet paralysis, patient can't shout, you will not even know that the patient has died. It's a terrible way for a patient to die because they take organophosphate and then you save the life and then you go home and come in the morning to see find the patient dead. So it can be quite awful. The management of that, atropine is not effective. The only effective treatment is intubation and ventilation. If a patient on day 4 or so gets respiratory paralysis after organophosphate poisoning due to due to intermediate syndrome, the only useful treatment is intubation and ventilation. Because of this reason, I always suggest that never ever to discharge a patient with organophosphate poisoning, however well that patient is, before 7 days have gone, before the risk of intermediate syndrome has completely gone away. නැත්තම් බස් එකේදී මැරෙනවා ලෙඩා. intermediate syndrome මම ඒකට ජයන්තිට ඇහෙනව නේද මං කියන එක? ජයන්ති නේ කාංචනා ඇහෙනවද?
Yes sir.
හරි කාංචනා, එතකොට මම ඔකට තවත් පොඩි කතාවක් කියන්නම්. one more story. These are all real stories I'm telling you. Once I was on call when my Dr. Harshini, she called from the psychiatry ward saying that there was a transfer from a peripheral hospital and for somebody who had taken poisoning for a psychiatric assessment, and she thinks that this is intermediate syndrome. The patient is not breathing very well. She called and said, and then I was on call, and then they didn't have resuscitation equipment at the time in their ward, so advised them to bring the patient to the ETU. They carried the patient down those stairs to the ETU, and I went with my team registrar. And by the time actually we got to the ETU, intubated, but by that time the patient had suffered hypoxia and patient died soon after. What happened was patient had gone to a regional hospital with organophosphate poisoning and then given atropine, pyridoxine, everything. Patient recovered very well by day 2 or day 3 or something. And then when they took a history, the patient has had depression. And they referred to the local psychiatrist who said the patient needs ECT. And then no medical treatment was going on. By this time it was day 4. And they said to give ECT, you have to transfer the patient to Karapitiya. Now nobody noticed that the patient was breathing less and less and less. They were worried about his depression because they had assumed that the organophosphate poisoning was over. So by the time the patient got transferred, he was almost in apnea by the time he got transferred. And then what happened was in the OPD also, okay, transfer come to the psychiatry ward for ECT, so they also didn't see the patient properly. They sent the patient to the psychiatry ward. So by the time the patient came to the psychiatry ward, patient was almost not breathing. So whatever efforts that we put in, the patient died. So I tell you the story to remember that organophosphate patients can die even after complete apparent recovery. They can die on day 4 or day 5. You must never discharge an organophosphate poisoning patient till day 7. You must always look after the patient till that time. Be very mindful of intermediate syndrome. Hari neda Kanchana?
Yes sir.
Now then ඔයගොල්ලන්ට මම මේ tutorial එකේ poisoning ගැන organophosphate poisoning ගැන I spoke to you about a case scenario and asked you some questions and taught you a little bit. Now as I always tell you, we set exams. That is, I set exam questions from the patients that I see. Right? So I will now show you a typical MCQ and an essay question which should appear from, say, organophosphate poisoning. MCQ. Which of the following poison antidote matchings are correct? කාංචනාට පුළුවන් ද කියන්න මේක organophosphate pyridoxine හරිද මේ antidote correction organophosphate pyridoxine atropine නෙවෙයි pyridoxine කියලා තියෙනවා හරිද මේක?
True.
Very good, excellent. මම එදා කියලා දුන්න point එක මතකනේ. දැන් ideally organophosphate වල antidote එක atropine නේ. So pralidoxime කියන එක 100%ක් හරි නැහැ. හැබැයි මම කියන්නේ MCQ එකේ හරි නම් හරි true. වැරදි කියන්න බැරි නම් ඒත් true. වැරදි නම් විතරයි ඒක වැරදි වෙන්නේ. So pralidoxime වැරදි කියන්න බෑනේ නේ. නේද කාංචනා?
Yes.
Though it's not 100% correct, ඒක වැරදි කියන්න බෑ. ඒක හින්දා it becomes true. Carbamate atropine. නෝට මතකද නැහැ carbamate poisoning ගැන? Are you able to answer this?
No, sir.
Don't worry. Carbamate is, remember, very simple. Exactly organophosphate. Same clinical features. Everything is the same. Only thing is, because of the way carbamates work, there is no place for pralidoxime as antidote. Harry? Pralidoxime, no place for carbamate. But atropine, yes. So management is exactly like organophosphate. So this answer then becomes correct or wrong, Kanchana?
True.
True. Absolutely. Carbamate atropine. That's correct. Digoxin salbutamol. Digoxin poisoning salbutamol. Is this true or false? Kanchana, again.
Don't know.
Don't know. Right. This is wrong. Digoxin poisoning causes heart blocks. Heart blocks never get corrected by salbutamol. I know that salbutamol, heart blocks, but that doesn't work. The digoxin poisoning comes about due to either Kaneru poisoning or again yellow oleander poisoning. Then there are certain other compounds. Sea mango කියලා තියෙන එකක්. Those are මට ඒක මතක් වෙන්නේ නැහැ ඒක නම. But there are certain other digoxin containing ones. Classic one is Kaneru. Have you all seen Kaneru inside the faculty? තියෙනවනේ?
Yes, sir.
faculty මම හැමදාම කියනවා ඩීන්ට ඔක ගලවල් දාන්න කියලා නැත්නම් අපි විභාගයට පස්සේ අර මෙඩිසින් පේපර් එකට පස්සේ කවුරු හරි ගිහලා ඕකම කයි කියලා ඉවර වෙලා. So hopefully nobody will take that. So anyway, digoxin poisoning heart, the cardiac pacing is the answer. Harida, cardiac pacing, not salbutamol. Paracetamol, methane. Sorry.
Sir, for digoxin poisoning, digibindin, is that the correct answer?
Right. Okay. That's another story. A digibind is an antibody. It is acts against digoxin. There was about 10 years ago, or 10, maybe about 15 years ago, there was a trial conducted in Sri Lanka on developing an antibody for Kaneru poisoning. So that is digoxin poisoning. So all the research was done in Sri Lanka on Sri Lankan patients, and there were publications in the Lancet and all that from Sri Lankan authors and collaboration. ඊට පස්සේ කරේ කවුද? ඒක පොඩි කම්පැනි එකකින් තමයි ඇන්ටිබඩි එක හැදුවේ. ඇන්ටිබඩි එක හදලා ඇන්ටිබඩි එක අයිඩෙන්ටිෆයි කරලා පස්සේ they sold it to another big commercial manufacturing organization. So they produced this digibind antibodies. Now antibodies course එකක් අරගත්තාම එක detector costs about $10,000 US dollars. No, 10,000 නෙවෙයි. Sorry, it costs ලංකාවේ සල්ලි වලින් යනවා, it takes about 1 million rupees. දැන් ඩොලර් එකත් ඒක පොඩ්ඩක් වෙනස් වෙනවා. I think about $5,000 වගේ වෙන්නේ. ඉස්සර තමයි $10,000 වෙනවා. yeah, $5,000 විතර වෙනවා ඒක. නෑ දැන් $10,000 වෙනවා. So anyway, දැන් ලංකාවේ ඒ බෙහෙත නැහැ. ඔය අහපු හින්දා කියන්නේ digibind කියලා බෙහෙත ලංකාවේ නැහැ. The reason is the Sri Lanka, we just cannot afford that antibody that is available for digoxin poisoning and Kaneru kind type of poisoning for Australia and those countries. In Australia there is a fair amount of digoxin poisoning. So all the research done in Sri Lankan patients, that knowledge is now being used to treat Australian patients. Sri Lankan patients did not get anything at all. So there was a big controversy about this, and now there are stringent measurements against doing research in Sri Lanka and producing medicines which are not going to be available for our people. So Your answer is absolutely correct. There is an antitoxin antibody, but that is not available in Sri Lanka. Because that is not available in Sri Lanka. So in Sri Lanka, what we do is cardiac pacing. How they prashne have it? That was a good question. How they have it?
Vimarsha, sir.
Vimarsha, now are you clear with my answer?
Yes, thank you, sir.
Yeah, so that's why you have never seen that. Candida poisoning on pace karna dakaladi, you have never seen the antibody. That's the reason. Paracetamol, methionine, is that correct?
True.
Paracetamol, methionine. Janti, Kanchana, Harida?
True, sir.
True,
Correct.
absolutely, yes. Yeah, you can use it orally. IV, if the patient comes within 8 hours and if the patient is not vomiting, methionine is a very cheap oral antidote for paracetamol. That should be the first line. 2 conditions. If the patient comes after 8 hours, it has to be N-acetylcysteine. If the patient has vomiting, it has to be N-acetylcysteine, because the patient will not be able to retain an oral drug if the patient is vomiting. But very important, if you are going to give methionine, don't give activated charcoal. Not activated charcoal, methionine, that will also be passed through the stools. So methionine, that answer is correct. Then morphine and flumazenil, is that correct?
False.
False, yes, diazepam and flumazenil. So again, this is the kind of MCQ that you will get. So MCQ will come from knowledge of this condition. So I have shown you how to make an MCQ. Now, this is an SCQ. Look at this. A 25-year-old female patient is brought to the OPD tube by the relations. She is conscious but drowsy. Patient has been feeling sad and down for a couple of weeks due to a breakup of a relationship. When she was found in a drowsy state by the family, she told them she poisoned herself by drinking from a bottle of agrochemicals. It has been about 1 hour since she has taken the poison. Anna scenario. But I asked you to imagine. So these are the questions that I would set from this. List 4 symptoms and signs of suggestive of organophosphate poisoning and describe the pathophysiological basis for their presence. Maraine muscarinic hatarai, manari muscarinic hari, nicotinic hari, central hari features, symptoms hatarai, signs hatarai liwa, and then you explain the fact that organophosphate is acetylcholinesterase inhibitor. Because of that, acetylcholine increases, and acetylcholine working on nicotinic receptors and muscarinic receptors produce the above symptoms. 20 out of 20 . Then describe the measures that you will take for GI decontamination. I would expect you to say, I will not induce vomiting because it is harmful to the patient. 2, as the patient has come within 1 hour and patient has taken a life-threatening dose, I will arrange gastric lavage. But because the patient is drowsy, I will intubate the patient, cuff the endotracheal tube, put an NG tube and do gastric lavage. Once I finish the gastric lavage, I will give again, because the patient has come within 2 hours, activated charcoal 50 grams. I will give via the NG tube. 20 out of 20. Tungani prashna. List antidotes that are used in OP poisoning treatment, describing the pharmacological basis of the actions. Atropine, atropine is an anticholinergic agent. It will, because organophosphates increase acetylcholine at neuromuscular junctions and postganglionic synapses. This anticholinergic medicine will go and inactivate the acetylcholine, thereby normalizing the effects. Pyridoxine is a second antidote. It breaks the bond between organophosphates and acetylcholinesterase. Same is said. Describe in detail how you will administer these antidotes. කතාව කියනවා මුලින්ම අර symptoms පහ බැලුවා. symptoms පහෙන් ඒවා එකක්වත් තියෙනවා නම් එහෙම break 4 vials and then give bolus dose, check in 5 minutes time, give another bolus of 8 vials, check in 5 minutes. If they are there, give break 16 vials, and like that, give 16 vials every 5 minutes till
the lungs are clear, systolic blood pressure more than 80 and pulse rate more than 80. And at that time, you will start an infusion of atropine using 1/5 of the total number of vials broken and give that dose every hour, and then gradually reduce the atropine dose looking at the 3 parameters. Pralidoxime, you will start along with atropine, give 1 gram IV infusion, and thereafter IV loading dose in 20 minutes, and thereafter IV infusion, and you will continue the pralidoxime infusion for at least 24 hours after stopping atropine infusion. Harida Kanchana, Tavisa Kanpulane?
Yes, sir.
And then Kanchana Tiana, Visa, Kanchana Palayan Visa Kanpulanda?
Yes, sir.
Devani Visa?
Yes.
Tungani Visa?
Yes.
Puluan. The Hataran Visa Gata, it was the Kanchanata, then Asuatiana, Ilanganatin Tavisai. Patient recovers by day 4 and is clinically well. Your consultant instructs you to retain the patient in the ward for another 2 hours, 2 days. Discuss the pathophysiological basis for his advice. The patients will get the patients will get intermediate syndrome where there is muscle paralysis due to fat-bound organophosphates being released, and these organophosphates will cause another crisis where the patient will lose muscle power, unable to lift the neck off the bed, and poor respiratory affair, and a patient will die. To prevent that, you will assess the patient with bedside spirometer every day and neck muscles, and if there is any respiratory weakness, you will intubate the patient and ventilate the patient. Lakumisa Ganapuranda Kanchanata?
Yes, sir.
And Kanchana has, how much have you got, Kanchana? That's a lot of marks. That's a lot of marks for a SCQ Kanchana. So you can see make a mara lazy tropical monkey poison they can hand pull may the essay question like but that those are rare. It's not fair to ask undergraduates. Undergraduates sort of fair question like paracetamol, organophosphate with organophosphate mono ahuat මේවගේ scenario එකක් තමයි දෙන්න පුළුවන් මේ වගේ ප්‍රශ්න ටිකක් තමයි අහන්න පුළුවන්. but මේ ප්‍රශ්න ටිකක් දිහා බලන්න මම නිකන් අහලා නැහැ this physical science this investigations ඒවා නෙවෙයි මම අහලා තියෙනවා pharmacological basis pathophysiological basis මම ප්‍රශ්න හදනකොට මම ඒ වගේ පොඩි කැලලක් දානවා ලොකු චූටි කැලලක් දානවා just to see whether you can actually give a scientific reason. ගැන අඳුරෙන් එළියට නෑ මේ යන්නේ අවිද්‍යාවේ විද්‍යාවට නේ අපි යන්නේ නේ scientific reason එකක් දෙන්න මේ උත්තරේට පුළුවන්ද කියලා. So no medicine in a scientific way, then you're okay. කාංචනාට මේ MCQ එකත් පහම හරි ගහන්න පුළුවන් නේ? කාංචනා පහම හරියට ගහන්න පුළුවන් නේද?
Yes, sir.
Wonderful. Absolutely. So you have done very well with the MCQ and the essay. Any questions from anybody? තප්පර 15ක් දෙන්නම් ප්‍රශ්න තියෙනවා නම් අහන්න නැත්නම් we will finish for the day.
So if MCQ is given as give the next most appropriate step and they give options like give oxygen via face mask and some other ones and then the antidote, what will be the next appropriate step?
Atropine. කිසිම කතාවක් නැහැ organophosphate වලට ඒ කියන්නේ අපි කවදාවත් දැන් මම ඔයගොල්ලන්ට ඉගෙනුවාට GI decontamination and දෙවැනි එක හැටියට antidote there is nothing in the world to say that එකකට පස්සේ අනිත් එක කරනවා කියලා. You do these things in parallel. හරි? Parallel. So ideally the patient should be given GI contamination එකට NG එක දානකොට එහා පැත්තෙන් atropine එක ගහන්න පටන් ගන්නවා. but ඔයාගේ immediate next step කියන්නේ එතකොට බලන්න ඕනේ patient ගේ තියෙන ලොකුම ප්‍රශ්නේ විසඳන්න පුළුවන් කොහොමද කියලා. Oxygen, this is not due to lack of oxygen or something. So there is very clearly in atropine the most important single ඔයා ඉතුරු ඔක්කොම නොකර හිටියත් කමක්. Even if you forget gastric lavage, forget activated charcoal, forget oxygen, forget IV fluids, forget everything, it doesn't matter. If you give atropine, patient will live. Harida, immediate next step is atropine. Any other questions?
Sir, if patient going to atropine poisoning during the course of treatment?
Yes, atropine poisoning causes patients to become confused and restless and all that. So, I mean, ideally they should not, because what you will do is you will be monitoring the systolic blood pressure and pulse rate. You will be reducing the manage karot atropine poisoning in atropine poisoning out infusion all you do is you reduce the dose of atropine. But atropine poisoning out confusion out we might give some sedative or something like that. But atropine has to be continued looking at the cardiovascular and the respiratory parameters. Harida.
Okay, sir.
Okay. Any other questions?
Sir, excuse me. Sir, there's the only indication for the ICU admission is that this respiratory services.
Only indication for ICU
ICU admission for
ICU yeah. That is ventilation, mechanical ventilation විතරයි ICU එකේ අපේ වාට්ටුවක කරන්න බැරි එකම දේ. හරි? මොකද අයිනෝට්‍රොප් දෙන්න පුළුවන් අපේ වාට්ටුවේ. NIV දෙන්න පුළුවන් අපේ වාට්ටුවේ. අපේ වාට්ටුවේ ඕන දෙයක් කරන්න පුළුවන්. කරන්න බැරි එකම දේ තමයි mechanical ventilation. So if that question is ever asked from you, yes, your answer is correct. It is only for intubation and ventilation. That is all. Not for anything else. ICU කියලා තරම් ලොකු තැන් නෙවෙයි. ඒක අපිට කඩි කරන්න පුළුවන් එක දෙයයි තියෙන්නේ. ඒ තමයි mechanical ventilation. Everything else we can do in our ward. හරිද? Any other questions? Jan, Kanchana?
Yes, sir.
Any questions, Kanchana?
No, sir.
Hari, එහෙමනම් මම දැන්ට නවත්තන්නද? Are you all okay? Right, I hope this has been useful. As always, I'll be very grateful if you can give some feedback on my මගේ email එකට එවන්න පුළුවන් නම් I will මම වජිත් අහගෙන ඉන්නා නේද වජිත්? Hello?
Yes, sir.
මේ වජිත් මගේ email address එක මම කලින් වාට එවන්නේ ඒගොල්ලන්ට කියන්න.
Yes, sir.
ඒගොල්ලන්ට if they have lost that, can you send it to them? I'll really love some feedback from you. Thank you so much. Even last time some of you had sent feedback. I'm very grateful to you. It's based on your feedback that we can actually become better and kind of serve you better. Right, and then have a pleasant evening. Take care. Stay safe. See you all soon. I miss you a lot in the ward. Okay.
Thank you, sir.
Thank you.
Okay. Bye.
Thank you, sir.
Thank you, sir.
Bye.
Thank you, sir. Thank you.
You're welcome. Bye.